Good morning, good afternoon, good evening, everyone. Welcome to the data collection webinar series. Today's topic is using MICS and DHS to estimate mortality among children, adolescents, and young people aged 5 to 24 years. This is the fifth webinar of the 2024 edition of the series, which is organized by the Data Collection Unit at UNICEF headquarters. I am Attila Hanjoğlu. I'm the Chief of the Data Collection Unit and the Global Coordinator of the MICS program at UNICEF headquarters. This edition of our series is, as many of you know, is focusing on the MICS program. We are diving into different aspects of MICS implementation at country level, the new modules, tools, and features that we have brought in as part of MICS 7, as well as methodological advances that we are making. This series of webinars are held about every 2 weeks on Wednesdays from 8 a.m. to 9:30 a.m. Eastern Standard Time. Today's webinar, as I mentioned, is entitled Using MICS and DHS to Estimate Mortality Among Children, Adolescents, and Young People aged 5 to 24 years. I will present our speakers in a minute, but before that, some housekeeping rules. Again, we have scheduled about 1 hour and 30 minutes, including Q&A. Throughout the webinar, please remain muted. Kindly write your questions in the Q&A box, and we will try and group your questions and direct them to the presenters during the Q&A session. The webinar is being recorded and will be available both on the MICS YouTube channel as well as the UNICEF SharePoint site for UNICEF staff members. You can find the links to both of these in the announcement that you received earlier. So today we have two presenters. We are very happy to have with us Danzhen Yu, who is the Chief of Demographics and Senior Advisor, Statistics and Monitoring, Data and Analytics section at UNICEF in New York. And we have Bruno Masquelier, who is a professor of demography at the Center of Demographic Research at University of Louvain, Belgium. I believe Danzhen is going to kick off. So Danzhen, the floor is all yours.
Thank you, Attila. Good morning, good afternoon. I'm very happy to be here today to present, this topic together with my colleague Bruno. And this work is based on the work of the UN Interagency Group for Child Mortality Estimation, and we call it UNIGME, UNIGME. And for this work, Bruno is leading the technical analysis, etc. So very happy to be here today, both of us. Next, I will talk about the content of this presentation. Before we dive into the survey data, etc., we will cover a little bit on the current status of mortality for this age group, from age 5 to 24. And secondly, we will talk about how to estimate the mortality in the different age groups, in 5 to 14 and 15 to 24, and the relevant 5 years age group, etc. And the third one is to synthesize survey data and other data sources to reconstruct the national trends. That is the methodology UNIGME used. And the last but not least is using DHS and the MICS to investigate mortality inequities in old children and adolescents. So I'll start with some numbers. In 2022, based on the UNIGME estimates, 2.1 million children and youths aged 5 to 24 died which means this age group, the deaths in this age group account about 30% of total number of deaths from age 0 to age 24. Next. And this number means that a death in the age group 5 to 24 occurred every 15 seconds. This is the last column of this slide. And this translated to nearly 4 deaths in this age group every minute. And we can also see the number for every hour and every day here, which are very large. Next. And regarding the progress, the decline in this age group since 1990 is a bit slower than the decline for the age group under age 5. We can see the different trend lines here, and the orange line is for this specific age group from 5 to 24. So we do see it's lower than the neonatal mortality rate and under 5 mortality rate, but we do see a slower trends here for decline. Next. And this slide shows the trends, the mortality rate in different age groups by region, and the black line in the middle is for the world. So we can see different regional patterns here, but they are more or less similar across different age groups, but the levels are quite different. And for the age group 5 to 9, we do see it's the lowest level among all of the age groups, almost in all of the regions. Next. And we also see mortality disparities across regions. From this map is very clear. And the highest risk is happening in sub-Saharan Africa. And you can see some dark color here, which means higher mortality rates among this age group. But this is for adolescent mortality specifically, which is for the age from 10 to 19. Next. Now I'll talk a little bit about the UN Interagency Group for Child Mortality Estimation. The IGME was formed in 2004, and the objectives include the following. The first one is to produce consistent estimates of child mortality worldwide for reporting our progress on child survival goals. And the second one is to improve methods for child mortality estimation, including methods for data quality assessment, and also statistical modeling approaches, etc. And the last one, but not least, is to build and enhance capacity of countries to produce timely and robust estimates of child mortality. Next. So we have a technical advisory group, and Bruno indeed is a member of this technical advisory group, and it's independent and composed of leading experts in demography, statistics, biostatistics, and public health, etc. And this group provides technical guidance on methodology, on technical issues, and the strategies for data analysis and data quality assessment. And we usually have 2 meetings every year, but now reduced to one meeting every year during the pandemic period, but probably will go back to 2 meetings in the near future. Next. just the three categories of the work I want to highlight here for the UNICEF. The first one I already talked about is estimating the global monitoring the reporting for the mortality of children, adolescents, and youth. And currently we cover from age 0 to 24 for the mortality estimation work. But we are also working on subnational mortality estimation and on stillbirths and the stillbirth timing, and also mortality in equities, including under 5 mortality rate by Wells quintile, etc. So a lot of details here you can find on our website. And the second one is methodological development. I won't go into the details. And the capacity building, we organize country missions and regional workshops and other technical support to be provided to countries. And just to highlight, the estimates have been consulted with country government agencies. So every year we conduct a country consultation process and provide the platform for countries to engage in this estimation process and provide feedback to us. I think that is the last. Next one, I have one just to show the UNICEF estimation process. It's a complicated process, starting from compiling data and processing the data and do the modeling, and then extrapolate to a certain year, and then producing reports and upload into the UNICEF data portal, etc., and the country consultation process as well. And sometimes we also organize workshops during the country consultation process. Next, just to show the UNICEF website. So this is a website. We put all the relevant information here, and you can find a lot of details regarding methodology and also regarding country-specific data and estimates. So if you don't know about the website, welcome you to visit. I'll stop here and hand over to my colleague Bruno to talk more about the on estimating mortality for these age groups.
Okay, thank you, Danzhen. So we will now look at how we can extract mortality estimates for the age groups 5 to 14, meaning completed 14, so up to age 15, and 15 to 24 or 25, I mean the 25th birthday from survey data. When you are interested in estimating mortality in young children, typically you will have various instruments in the household surveys. The first one is the summary birth history, and this is just a number of total number of children ever born and surviving of women of reproductive age. But unfortunately, this approach is not useful for capturing mortality in older children and adolescents because no method has been developed to use the summary birth history data for those age groups. So we typically don't use that in the UNICEF process. We can use the full birth histories. Those are the complete list of all the children born to women of reproductive age with their sex, date of birth, vital status, current age if surviving, and age at death if disease, and so on. And that allows us to estimate mortality using a direct approach because we know the number of deaths and the population at risk for specific age segments and periods. And we will see how we can then use that to estimate mortality above age 5. Some surveys, typically the malaria indicator surveys in the DHS program, have used truncated birth histories, whereby women are asked about their most recent births, typically those who occurred in the last 6 years or the last 3 to 4 births. But again, this will not be useful for measuring mortality above age 5, because we will only cover the most recent birth. And then lastly, surveys and typically censuses can also interview household head about all household members who died in the preceding 12 months and ask about the sex and age at death of those household members. And that also allows us to estimate mortality directly, including for the older age groups. So this is just an example of a summary birth history set of questions. This is coming from the MICS Afghanistan 2010 survey. And you see the questions are limited to the number of children ever born, those who are still at home, those who are elsewhere, those who have died, disaggregated by sex. And typically to estimate under 5 mortality from there, we can compute the proportion of children who are deceased out of those who are ever born and convert those proportions into risks of dying using standard age patterns of mortality and fertility. But this is an area of development for older children and adolescents. We need to develop similar methods to make use of such data. This is an example of the set of questions that are asked to collect full birth histories. This is the Sierra Leone 2019 DHS. And you see there that you have the age at survey or age at death. And then you can apply a direct calculation because you can divide the death by the person years in specific age groups and periods. How can we do that in practice? Well, typically we will first download the DHS or MICS data sets. They usually come in the format of the birth history, so meaning one row for each child. And what we will do is to split the life course of each child, depending on the, we will split every time the child reaches a new age, or every time the calendar year changes, or every time the time prior to the survey changes. And so we will typically break down this life course into different spells and then aggregate all the different spells to form what we can call person periods. This is typically a unique combination of a given age and sex and time prior to the survey and calendar year. And once we have aggregated those person periods, we know for each combination the number of deaths. We can divide that by the population at risk to compute monthly or yearly mortality rates. Then we convert those mortality rates into probabilities, risk of dying, and chain them together to obtain summary indices, such as you see here 5Q0, this is under 5 mortality, or 10Q5, this is the risk of a child age 5 dying before reaching age 15. So if you are interested, several R packages are available. There might be other tools for Stata. And if you're using R, I would recommend using the package dhs.rates, which is widely available and can help you reproduce exactly the estimates from the DHS reports, and I guess also the MICS reports, but it's limited to mortality below the age of 5. If you're interested in the older children's, and you want more flexibility, you could also use the DemocServe package, which is available on GitHub, and allows you to stratify indicators by education of the mother or region, and specify the age group that you are interested in and the periods that you are interested in. So one thing that we should be aware of, two things that we should be aware of when we estimate mortality in older children aged 5 to 15 from full birth histories, is that, as is the case for under 5 mortality, there is a risk of misreporting errors because we are using retrospective data. And so we should be investigating that very closely. Although there is little research on the quality of information provided on children aged 5 to 14. Another aspect that we should pay attention to is the truncation bias. By this, I mean that only a fraction of women aged 15 to 50, those women are typically interviewed in the MICS and the DHS, will be reporting on children born 5 to 14 years prior to the survey. So in this diagram, you see, I don't know if you see my mouse or not. Danzhen, do you see my mouse? Yes, okay. So this is just the cohort of women who are being interviewed, right? And they are reporting on those children born here in blue who will be contributing to death and person years in the 5 years prior to the survey. Imagine here that we have a survey conducted in 2024. So the children that we are interested in are typically born from 5 to 20 years prior to the survey. And those births, they come from those mothers, but they also come from older mothers, right? But those mothers, they typically will not appear in your sampling frame because of the truncation, because women who are now older than 50 will no longer appear and will no longer contribute to the full birth histories. So that has implication because what you will be working with when you use a full birth history to estimate mortality among older children and adolescents is typically high-risk firstborn children and children born to younger mothers, because those who were born to older mothers with high parity, they will no longer be appearing in your sampling frame, in your full birth history. And this is the reason why when you look at adolescents age above 10, above 15, and even youth up to the age of 25, we might be in need of other instruments. And so what kind of instruments do we have to estimate mortality in the older age groups? We can use summary sibling histories. This is the number of siblings of the respondent and the number of siblings who survived. We can use full sibling histories. This is it's basically similar to a full birth history, but it's the history of the mother of the respondent, not the respondent herself. So this is the number of maternal siblings of the respondent, the survival status of those siblings, if alive, their age at the time of the survey, if they died, how many years ago they died, and how old they were when they died. And again, we can also use recent household death, although this is typically collected in censuses and few surveys have included this module. So this is an example of questions that are asked in the DHS to collect sibling survival histories, which I will call SSH. And you have additional questions to identify pregnancy-related death. So historically, the sibling survival histories, this module has been used to capture maternal and pregnancy-related mortality, but we can, of course, also use it to estimate all-cause mortality, including in males. And so here is the diagram again. Depending on the age group that you are interested in, sometimes it would be preferable to use full birth histories. Sometimes it would be preferable to use sibling survival histories. And I think more research is needed on how we can combine them and what are the advantages and disadvantages of each instrument. So in this diagram on the left, you see I will be estimating mortality, the probability 5Q5. This is the risk of a child age 5 dying before age 10. And in this case, probably the full birth history is the correct instrument to use. But if I want to estimate mortality from age 15 to 20, in this case, those adolescents, they were born quite some time ago, and the women who give birth to those adolescents, they are in part now excluded from the sampling frame, from the full birth history or full sibling history. So in this case, it might be preferable to use the sibling survival histories and use information on the brothers and sisters of the respondents rather than on the children of the respondents. But it's interesting to note that because of those differences, the full birth histories and the sibling survival histories, they don't tell us the same story. So in this graph, I show, I'm using the DHS here because I want a large number of surveys with sibling histories. And I'm showing the probability 5Q5 from full birth histories on the x-axis and from sibling histories on the y-axis. And you see that typically the sibling survival histories, they provide higher estimates of this risk of dying. And the same is true when I'm looking at mortality from age 15 to 19, and you see that there are some significant differences. So we might wonder why are they not fully consistent? And I think the reason for this is that there are structural differences between full birth histories and sibling survival histories in terms of maternal age. Typically, children that are contributing to birth years and death in the age group 5 to 19 are born to older mothers in the SSH compared to FBH. And they are also of higher birth order in the SSH. And so if we have association between maternal age, birth order, and mortality, that can explain the differences between sibling survival histories and full birth histories. Typically, what we've been doing for the UN IGMI work is to use birth histories below age 15 and sibling histories above age 15. But this has implications because fewer surveys have collected data on siblings. So our database is a bit less complete, comprehensive when we look at adolescents age 15 and above. Okay, now that we've decided which instrument we will be using, we also need to look at the data quality and decide which survey we will include or exclude when we try to reconstruct mortality trends. And for this, what we've been doing is to look at the plausibility of age patterns. This plot shows you the relationship that exists between under 5 mortality on the x-axis and mortality in youth from age 15 to 25 on the y-axis. And you see with this cloud of points is coming from high quality vital registration data from the human mortality database. Those are the gray dots. We also added information from HDSS. Those are small areas where the population is followed prospectively with high quality mortality data. We also include the sample registration system in India and the vital registration in Mauritius. And basically we have this relationship that tells us, given a level of under 5 mortality, what is the level we would expect in youth in terms of mortality from age 15 to 25. And what we do when we have a new survey is that we look at this relationship in the survey. And if we find a point that is above or below those intervals, those prediction intervals, we will tend to discard the survey on the basis of concerns about data quality. Now, how can we, once we have those surveys and other data sources, how can we combine them together? And what can that tell us about the quality of survey data? So I will then go back to some parts that Danzhen presented about the UN IGMI estimates to show you the state of information that we have on those risks of dying globally. So we have built over the last few years 2 databases which include about 8,800 country year data points for each age group. And we have also disaggregated that by 5-year age group. And if you are interested, those databases are publicly available. You can download the database through the website that Danzhen presented earlier, the childmortality.org. What do we have on those databases? First, we have vital registration data, but this is only covering 28% of the population that we are interested in here. So this is mainly high income, low mortality countries, and not where the burden of mortality is concentrated. Then we have some information from sample registration systems such as in India and other country-specific systems such as the rapid mortality surveillance in South Africa. Then we have reports on recent household death from censuses or large-scale surveys. And finally, the surveys that we are interested in today, coming from DHS, coming from MICS, coming also from the World Health Surveys or the Reproductive Health Surveys, the PAPFIME program, so many other different programs. And what we do is we estimate mortality directly from full birth histories below age 15 or sibling histories above age 15. We use a stratified jackknife approach to compute confidence intervals because we want to know whether the estimates are uncertain or not. And we only include information referring to the 12 years prior to the survey. And we will split those 12 years. If the sample size is large enough, we will take several data points from a single survey. If the sample size is too small, we will typically have only 1 point per survey. Those are 3 examples here, not referring to, they're referring to specific countries. The first one is an example with a data-rich country with small variations across surveys. You see the different surveys are quite consistent here. This is the risk of a child age 5 dying before age 15. And this is an interesting case because since we trust the vital registration data or some sample registration data, we can use this information to model the biases in the surveys as well. In the middle, you see a case where we only have 3 surveys. They're not really consistent with each other, and they are highly uncertain. And finally, on the right, you have a case where we have some vital registration data, but it's not covering the whole period because we produce estimates from 1990 to 2002. 2022. But in this case, there might be some concerns about the completeness of death registration. This is a series of examples for the probability 10 to 15, so from age 15 to 25. Again, a country with vital registration data and some surveys. Another country where you have many different surveys, but again, with some uncertainty. This might be a case where we have some HIV because you see this increase and decline. And finally, a country where we only have vital registration data and maybe some information from recent household death, but we don't have sufficient information to run the model on this case. Okay, I know this webinar is about surveys, but just to point that surveys are critical in many countries because, as you see, the completeness of death registration is very incomplete in many countries. And typically what we have is a good coverage in high-income countries, but a very variable coverage in middle and low-income countries. And in most of sub-Saharan Africa, we don't have vital registration data in our model. We have been estimating death registration using death distribution methods. Those are demographic methods that tell you what is the share of deaths that are reported in the CRVS system. And when we think that the completeness is below 80%, we don't use the information. When it's between 80 and 95, we adjust it. And when it's 95 or above, we just include it without any adjustment. I will go really quickly on this point, but it's just to mention the different types of models that we are using to estimate mortality from age 5 to 15 or 15 to 25. We use the B3 model. B3 is for Bayesian B-spline bias reduction, and it was developed by Leontine Alkima and colleagues 10 years ago in 2014. And the same model is used for under 5 mortality. Typically, what the model does is it treats it treats the observed probability that you have as a product of the true probability and some error term. And it uses splines to guarantee some smoothness of the resulting trajectory that you have at the end. And it's important to note that the model does not exchange information across countries on levels or trends. It only exchanges information across countries in the variability in changes between the spline coefficients. So it exchanges information about the smoothness in a way. And a key element of the model is also that it includes a data model that accounts for stochastic standard errors for the vital registration and potential biases in trends and levels in the survey estimates. It's a Bayesian model. We use an MC algorithm to sample from the posterior distribution of the parameters, and we produce estimates for 200 countries from 1990 to 2022. And as has been mentioned earlier, those estimates have just been updated and they are available online. I'm mentioning this because the model can also be useful for us to have a sense of the biases that are present in the survey estimates. And it modeled the biases as a function of the retrospective period of the observation. So this is the case here of the risk of dying from age 15 to 25, noted 10q15 again. Let's assume that the true value is 15 per thousand. What do we get from the DHS sibling survival histories? What do we get from other sibling survival histories? And what do we get from household death? The model would tell us that the DHS will be very close to the true 10q15 in the period just before the survey. But if we move further back in time, we will underestimate mortality. And that has been documented. There is some decline in the completeness of death reporting in the sibling survival histories if you move further back in time. By contrast, if we use household death, we will typically be a bit higher than the true level. And the model accounts for that to produce the final value of 10q15. And you also see that there is a lot of variability that comes from both variability in the parameters of the biases and sampling variability. Okay, so what do we have at the end? This is an example of Bangladesh, where you see the input data and the final estimates in red. And this is an example of Namibia, where we have different surveys with sibling survival histories in this case, because we are looking at the risk of dying from age 15 to 25. But you see that there is a lot of uncertainty in the most recent period because there is a lack of recent data. And this is in part because not all surveys collect sibling survival histories. Okay, to be fully complete, I should mention that in about 30 countries, we don't have enough data points to run the B3 model. And in this case, we infer the risk of dying in older children and adolescents from this expected relationship between those risk of dying that we are interested in and under 5 mortality. And there is still room for improvement here, but that only represents about 5% of the population age 5 to 24, because typically those are small countries with not many data points. In the past, we only produced estimates for both sex combined. In recent years, we have also released estimates by sex. And for this, we use a Bayesian hierarchical time series model that captures the relationship between the sex ratio, so the male to female ratio of mortality, and the mortality for both sex combined. And just quickly, what do we get from those estimates? We see that the sex ratio typically increases with age. So globally, it's 1.13 below age 5, 1.16 from age 5 to 15, and 1.65 from age 15 to 25. That set of estimates also tells us that males account for more than half of death, actually 56% of all death in the age group 0 to 25. And also we've seen in all age groups that the sex ratio of mortality has increased since 1990 because progress has been faster in girls than in boys. But we also see that excess female mortality persists in some countries. And if you move to adolescents, we also see excess mortality in males, especially in Latin America, possibly to disproportionate exposure to violence. Okay, I'm now moving to the final set of results. We have been discussing now how we can estimate mortality using surveys and other data sources at the national level. But can we use survey data also to look at disparities above age 5? If you look at the literature, every day we see papers coming out about inequities in mortality below age 5. But comparatively, there is little attention devoted to older children, especially those who are between age 5 and 15, which is like, those children are kind of falling in between the cracks. So What I will show you now is a set of estimates that come again from DHS. I wish I could also include some estimates from MICS, but I wanted to have a large number of surveys where we have both full birth histories and full sibling survival histories. And so we will be looking at a set of estimates that come from 54 different surveys. And basically just looking at the mortality by education, type of residence, and wealth quintiles. So here, what you see is a set of estimates of under 5 mortality by education of the mother in those 54 DHS. And if you compute the ratio between mortality of children with no education to mortality of children whose mother have a secondary or higher education, you would have a median ratio of 1.7. Okay? And we see here that we have a large number of surveys where those differences are significant. They are significant in 39 surveys out of 54. So it's not, nothing new here. We know that mortality is much higher when the education of the mother is low. But what happens if we go above age 5? Again, this is a mortality by education of the mother, but we're looking at the risk of dying 10 to 5, so from age 5 to 15. And the median ratio in this case is 1.9. So it's very close to what we have under age 5. We have fewer cases where the differences are significant, only 11 surveys in this case, but this is probably because we have now more uncertainty. We're looking at an age group where mortality is lower, but the main take-home message here is that disparities extend beyond age 5, and we should be having a closer look at those disparities above age 5. We can go up another 5 years and look at what happens between age 15 and 20. And this time it becomes a bit tricky because we're not using full birth histories, but full sibling histories. And so we're not comparing mortality of mothers, but mortality of sisters. And we have a median ratio of 1.7. And again, significant differences in 10 surveys. So main conclusion, again, we see disparities also in youth mortality when you use survey data. Okay, now that I've presented this in detail with education, I will go quickly to save some time for the Q&A, but this is by type of residence. Under 5 mortality, median ratio rural to urban is 1.4, significant differences in 33 surveys. Moving to 5 age to 15, a median ratio of 1.6, and between age 15 and 20, a median ratio of 1.1. So there might be some, indication that the disparities are reducing in this, in terms of rural-urban disparities. They might be reducing with age. By wealth quintiles, the median poorest to richest ratio is 1.5, significant differences in a lot of surveys. When you look at under 5 mortality, 1.8. When you look at mortality from age 5 to 15, 1.3. When you look at mortality from age 15 to 20, with fewer cases of significant differences. So to wrap up, we all know that unprecedented progress has been made in the fight against early childhood mortality. We have reached this stage where mortality is now low to the extent of bringing the number of deaths in children less than 5 below 5 million for the first time. We have reached this threshold. We now have 4.9 million deaths under the age of 5 in 2022, compared to 12.8 in 1990, as Danzhen showed earlier. But this impressive progress should not obfuscate what happens in older children and adolescents. And so care must be taken to ensure that older children and adolescents are not left behind. And in 2022, we estimate that 2.1 million children, adolescents, and youth died between the age of 5 and 25. And they died mostly due to preventable causes. There is a team that works on the causes of death, and there are also some estimates that you can see online where you can pinpoint the leading causes of death. And as Danzhen has showed, this the slower progress in older children and adolescents and youth also means that they are representing a growing share of premature death below age 25. As she said earlier, 30% of premature mortality below age 25 occurred between age 5 and 25. And lastly, we should be making a more systematic use of survey, the MICS and the DHS, to also look beyond mortality trends and also investigate disparities in the risk of dying, because they are well documented in young children, but they are also observed in older children, adolescents, and youth. And the surveys that we have at hand as not the data sets that we have not been systematically used to investigate those disparities. I think that's it. Thank you.
Thank you very much, Bruno, and thank you very much, Danzhen. Let's go into a Q&A now. And I will direct you the questions in the order which they came. The first question is how to model where we do not have completeness of data, because it would lead to inequity given the poor countries carry major burden of under 5 mortality and infant mortality. That's the first question that came in. I think you can also read the question from the Q&A box.
Do you want to take this question, Danzhen? No? Danzhen, do you want to take this question, or am I taking this question? You're muted, Danzhen. So I'm going to take this question while Danzhen connects. How to model where we don't have completeness of data. If we were to use only vital registration data, we would be missing, as I showed earlier, we would not have estimates for all the countries where mortality is concentrated. The share of death that occur in sub-Saharan Africa is increasing gradually, and this is true both for children aged less than 5 and for children, adolescents, and youth age between 5 and 25. So the work of UNICEF is especially important for those countries, and this is why we use such comprehensive databases that combine vital registration data, census data, survey data, and also use some statistical models. Because oftentimes we don't have the most recent data to have estimates for the most recent years, and this is also why we need models to have some kind of short-term extrapolations. Danzhen, do you want to?
Maybe just to add for under 5 infant and neonatal, we usually have data even for some countries without well-functioning civil registration system do have some data. Usually we do not have like a country do not have any data. So that's for the under 5 age group. But for neonatal, for example, data becomes very limited, and then we use the age pattern of neonatal to under 5 to derive the neonatal mortality estimate. So some kind of age pattern modeling approach, like that is also applied. And also, of course, as Bruno indicated earlier, for the old age groups as well, like the regional kind of patterns and the levels also applied into the modeling work. And of course, improve the empirical data and improve the data system in countries are critical, really, for the modeling work as well. But mainly really to ensure that we have timely and quality data, to do the reporting and the monitoring related work for child survival at the country and the local level. So that's one goal that we would like to really advocate for and provide support to countries, to do the relevant work. Yeah.
Thank you very much, Danzhen and Bruno. One of our participants is asking you to repeat the explanation of the higher rates in young population in Latin America.
Okay, my point was about the sex ratio. So what we've been doing is look at the sex ratio, male to female ratio of mortality in reference to the mortality for both sex combined. And when you do that for under 5 mortality, typically what you see is excess female mortality in countries where there is some discrimination against girls in terms of healthcare or nutrition. But when you look to older age groups, we see also a different patterns emerging. And this is the excess mortality of males, given the level of mortality for both sex combined. So it is like wondering what is the expected sex ratio that I should see in this country, given the status of the mortality transition. And what we see is both discrimination against girls in some regions, especially in South Asia, but in Latin America, we see excess mortality in males. And we believe that this is driven by exposure to violence, which will typically increase mortality in males, but to a lower extent increase mortality in females. So that might be driving why we see this high sex ratio in adolescent mortality in Latin America.
Thanks, Bruno. Just to mention to everyone that the presentation, the session is actually going to on the YouTube channel of MICS, and for UNICEF colleagues, it's going to be on SharePoint, so you can actually watch this video from there again if you need to. There's a question about whether it is possible to estimate the subnational indicators with this methodology. Of course, you did talk about the urban-rural differences, etc. But for instance, is it possible to come up with regional estimates of mortality using these methods?
Okay, I'm sure Danzhen has something to say about that, because this is a stream of work important for UNEB for the under 5s. Just briefly on the children above age 5, it all depends on the data source. If you have a census with recent household death, it would be possible to investigate subnational differences, but to come up with trends over time and look at changes in the regional or provincial estimates of mortality for those age groups, this will be a bit challenging. We have a paper where we look at that on the DHS data using a similar methodology that is used for under 5 mortality, but there were only a few countries where we had sufficient large number of surveys and sufficiently large sample sizes to be in a position to say something about regional disparities in the age group 5 to 14. We should look at this above age 15 also. We haven't looked at that. But again, this is, I think, an area where more research is needed, more attention is needed, because as there is this increasing attention to older children and adolescents, we also need to go subnational.
Thanks,
Maybe
Bruno.
just to,
Danzhen, go ahead, please.
just to add for the under 5 mortality rate and also neonatal mortality rate, we produce the subnational estimates for about 30 countries in this second round. And not for those countries usually have household survey data. We currently only using household survey data for subnational estimation work. And we use time space smoothing methodology and pulling together all the available surveys, not only use one survey to do the estimation work. And methodology was developed by Professor John Wakefield, who's a statistician, a professor in the University of Washington. And the relevant information you can also find in our data portal, childmortality.org. And those estimates have been widely used by partners and also even in countries, including some Ministry of Health, etc. They shared with their local government agencies for programming work.
Thanks, Danzhen. Bruno, you did talk about the sex ratio of mortality in Latin America based on a question. What is the situation in sub-Saharan Africa according to the data that we have? In sub-Saharan Africa, the sex ratio and mortality.
Okay. You mean for children age less
Five
than
and above. 5 and above.
All age groups. Let me check. Let
Yeah.
me see. I agree that sub-Saharan Africa has a situation which is, as you see on the maps. So on those maps here, you see the sex ratio below age 5, from age 5 to 15, and from age 15 to 25. And the circles refer to countries where we have a deviation from the expected sex ratio. So in sub-Saharan Africa, you see that it varies a lot, and sex ratio tend to be a bit high, but we see few cases where the sex ratio deviates from the expected sex ratio that we should see given the mortality transition. I would encourage you to look at the paper which was published last year to have more detailed country-specific estimates, and those estimates are also available online.
Mm-hmm. Is excess female mortality a feature mostly in South Asian countries?
Yep. And so what you see on those maps is that it is visible under age 5, but that excess female mortality is also visible above age 15.
Mm-hmm.
And it contrasts with what we see in males. The only situation where we have excess male mortality is in Latin America, mostly, and in adolescents above age 15. We don't see a lot of cases where we have excess male mortality below age 15.
Thank you. Is in settings like Yemen and Gaza, how do we go about coming up with these estimates in conflict situations?
Danzhen might want to take this one.
Yeah, so for countries in conflict or in fragile states, we do some adjustment for crisis mortality, but only on the direct effects. So we used some database from partners. They documented the deaths due to conflicts or disasters, etc. Then on top of our non-crisis mortality curve, we add this crisis mortality rate. So then we get the relevant the final estimates. But our estimates are likely to be underestimated, or maybe I should not say that, because sometimes the estimate could be also over. The numbers could be also overestimated due to other reasons, but maybe in many cases due to the that we didn't really account for the indirect effects, then it could be underestimated. but interventions in those countries in conflict, like the interventions from UN agencies and also NGOs and relevant country governments as well, sometimes would help also to really reduce the mortality rate, in not kind of to make it increase as we expect into a level. So that's why, for example, in the COVID-19 period, our analysis really didn't show any significant increase in the last 2 or 3 years for child mortality estimate, particularly for under age 5, for some adolescent and youth, we do see some increase. In addition to the protection effects from wearing masks, to reduce infection, disease, etc. The intervention from interagency groups and the public health communities also helped a lot. So this is a very complicated kind of situation and require more study and research. And we are trying to improve our methodology for crisis mortality adjustment. We have generated an analysis and also produced a publication, a working paper on age patterns of crisis mortality last year. So based on available data from partners, we compiled and we did a quality assessment and then modeled the age patterns of crisis mortality. So when we do not have data for crisis deaths or disaster deaths, usually when we have data, we only have the total. We do not have the data by age groups, detailed age groups. Then we use our model to develop the estimates for different age groups. So all of this methodology are available in our data portal. You're welcome to visit. There's a methodology, there's a publication section, and the methodology part is also under that section. And including this methodology to generate estimates for all the age groups, you can also find the relevant documents there.
Thank you very much, Danzhen. There's a question from one colleague. What is the difference between the light and dark dots in the slide that models the bias for different sources for the B3 model? There are light lines behind.
Yeah, this person has been very, paying attention.
Yeah.
So the difference is basically variability due to modeling the biases only, and so the dark colors and the light colors are when you add on top of that variability associated with the sampling.
Thank you, Bruno. Sibling histories are more commonly used to administer to female respondents in the women's questionnaires, and less so when it comes to men's questionnaires, which are included in the majority of the countries nowadays, I would say, in both MICS and DHS. Do you have an assessment of the quality of data that comes out of males and females for sibling histories?
Yeah, there is a study by Ken Hill and Lena Merdad in PLOS ONE, I think, published a few years ago, which looked at the surveys where they did collect information on siblings from male and female respondents. And the basic conclusion is that male reports are as reliable as female reports. And so their recommendation, if I remember well, was we should collect sibling survival histories from both males and female respondents. And there are two reasons for that. The first is that it might help us to better understand the selection biases, because people are reporting on a set of which they are a member, because I'm reporting on my siblings, but I'm also a member of this sibship. So there might be some selection bias involved, and I think if we have information on males reports and female reports, we can have a better sense of what's happening there. But it's a bit technical. The other less technical reason for collecting sibling survival histories from both males and females is that it would increase the number of deaths and person years. And this is especially important in age groups when you start looking at disaggregated, estimates like we are doing here. So indeed, we should more systematically include sibling survival histories from males and in the male and female questionnaires. But obviously, it also costs time and money. So I can understand that there is a focus on female respondents.
Mm-hmm. Maybe a question on, if I understand it correctly, more about data sources. Did you compare the estimates of DHS and MICS surveys with those from censuses to assess the coverage in some countries or regions, such as Sub-Saharan Africa? Is there a series of results for some specific countries, such as Cameroon, using the series of DHS surveys?
Okay, maybe quickly then on the older age groups again, and Danzhen might have some take on that for the under 5 mortality. The difficulty is that if you start comparing surveys with censuses, you are comparing different types of data collection systems, but you are also comparing different instruments. So basically, you're comparing sibling survival histories with recent household deaths, for example. If you compare the DHS or MICS instruments for mortality above age 15 with the census type of instruments that are used. So the comparison is a bit tricky, because if you see differences, is it due to the fact that we're comparing surveys with censuses, or is it due to the fact that we are comparing instruments? To my knowledge, no census, except maybe a few that I can think of, a couple of censuses have included sibling histories, but in this case, it's only summary sibling data. Mm-hmm. So it is difficult to combine and compare. And this is why such kind of statistical model is important, because it helps us to put all the data sources together and then model the biases together. What I can say about what comes out of this kind of modeling work is that estimates from recent household deaths tend to be highly uncertain. In some cases, they are way above what we expect. In some cases, they are way below, and we don't yet really understand why. It could be that there is some age misreporting involved. It could be that people are confused about the reference period. Like, did this guy really die 12, like 10 months? Is it included or excluded? It could also be about the notion of what is the household and what happens with the death with the household leads to some migration and dissolution of the household. So there are all many reasons why we can see recent household death being quite uncertain. But they are still included in the modeling work, but typically they come with a lot of uncertainty. I don't know, Danzhen, do you want to add something on that?
No, maybe just for the younger age group on the age 5. As Bruno already said, the different surveys or census, they use different methodology. Particularly for census, it's quite different from household surveys. They use household deaths, in the past 12 months, for example, usually, and even. DHS and the MICS, they have the indirect method or direct method. One use a summary birth history or full birth history. So, for the under 5 mortality estimation work in the model, we do using the model to estimate data bias by different surveys and the different data collection methodology. So for example, DHS for a birth history direct method and the MICS for birth history direct methods, the data bias, they are different. And between within DHS indirect methodology using summary birth history, and DHS direct methodology using full birth history. The data bias also different. So on the file mortality estimation modeling approach, we have those data bias estimated. And we do see for census household survey, the bias, for household deaths, the bias usually is larger than household survey results, particularly larger than the full birth history direct estimates. So, and the indirect methodology using summary birth history in household surveys, the bias are larger than full birth history direct methods. So the UN IGMI Technical Advisory Group now recommend for household surveys to use full birth history instead of using the summary birth history. Also not recommend to use the truncated summary birth history, which means only for the past 5 years prior to the survey. So we do have this relevant analysis included in the modeling approach.
Yeah, and if I may add something, if this person is interested in Cameroon in particular, I would encourage him or her to download the data which is available on childmortality.org and check, because it varies across census as well. In Cameroon, for example, one census can provide an estimate which is much higher than expected. Another one can provide an estimate which is much lower than expected in terms of the recent cause of death. But all those input data are publicly available, and the final estimates as well. So you can see to what extent they are consistent or not.
Thanks, Bruno and Danzhen. Yet another question about data sources, actually, which I think is interesting to address. The question is assuming that we have declining response rates and increasing data quality issues in household survey data, but where good admin data is available, vital registration data, for instance, is available, would you rather make use of that or try to improve survey data, or a combination of both? Maybe I can convert the question a little bit and say, is there a case to be made for household surveys to include, for instance, sibling histories and birth histories in situations when the vital registration data is of good quality?
So again, on the older children and adolescents, definitely, if MICS and DHS surveys conducted in countries where we have good reference data, be it like the rapid mortality monitoring in South Africa, or countries where we have decent death registration, it would be really, really useful to have full birth histories and full sibling histories to be in a situation to then conduct validation studies and so on. And I would also encourage survey programs to include information on death registration within those instruments, because how many siblings died, how many of those siblings were registered. So then it can go both ways. The survey program can inform the quality of the vital registration data, and the vital registration data can help better understand the biases in the survey instruments.
Thank you. There's a couple of questions on correlates of mortality. One is about the singleton and twin status and its effect on mortality, and another question on the effect of nutrition, both quality and quantity-wise, of the mother and the child on children's mortality. It's more about undefined mortality, I think, both questions, but still relevant, I think.
So I can take these questions for nutrition. Yes, definitely, malnutrition is a factor also, for higher mortality rates. I think some studies showed malnutrition contributed to 40% of under-5 deaths. It's not a direct cause of death, but it contributes to mortality. And for twins, we haven't really included in our estimation process to do the estimation work, but we do have some analysis on like birth order, birth size, the mother's age at birth, etc. But the data for twins, this singlet, is very limited. So how to improve the data and make data more available? That is kind of the first kind of question we have. Like we should do more advocacy work in that area. And I would love to see your study in this area as well. And it would be great to if you could also share with us, since you have done some study for the twins mortality. Yeah.
Mhm. Thank you, Danzhen. Causes of death. Of course, we are discussing methodologies to estimate mortality among children and adolescents and youth, and going one step further, do we also collect causes of death, which is I know it's even more challenging, but maybe I can hear from you guys on what you think about causes of death, both under 5 as well as the adolescent and youth group, especially in surveys, since this webinar is mainly about surveys.
Danzhen, do you want to take this one or?
Yeah, I can take it first. And so on cause of death, usually for surveys, we use verbal autopsy methodology to collect the relevant information, and there are some guideline document, on the questionnaires to be included, etc. There are different groups working on the questionnaires, but one group working with us, UNICEF and WHO, and also Johns Hopkins University. We also developed standard questionnaires for countries to use. So usually it may produce some good estimates, but before we use it, we really also need to assess the quality, because to get the information on cause of death, from surveys, etc., not directly from doctors, judgment or certification, death certificate, it is very challenging, and there are a lot of errors and bias around the information we gathered. So needed to be quite careful in using the information. But when we do not have another well-functioning CRVS system or health information system, then using household survey to get some relevant information on cause of death is also variable budget. So to note that we needed to be assured that the quality is good. And of course, for the cause of death estimation work, we have a group, and you can also find the relevant information on our website. And last year, we integrated the cause of death estimates into the UNICEF data portal. It is led by the CA code group, which is called Children, Adolescent, and Cause of Death Mortality Estimation Project, and led by GHU, Johns Hopkins University, and WHO, and UNICEF, and other relevant partners. So we have very detailed information regarding the methodology and also country-specific data and estimates. So you will find that the empirical data from countries, and what kind of data sources are available, etc. All the very detailed information also in the portal. And for this group, the estimates also are updated almost every year, but sometimes every 2 years. Yeah, so just visit the website and you will find a lot of information there.
Yeah, and maybe mentioning also that they are fully consistent with the all-cause mortality envelope, because those estimates are produced jointly, and I think they also go through a country consultation process as well, right? And so just briefly on the causes of death, I think this is, of course, if we want to understand why mortality is declining faster in this country or this country, in this age group and this age group, we definitely need to look at the causes of death. And obviously they will be very different from under 5s to older children to adolescents, because each age has a specific set of exposure and is also sensitive to specific interventions. Obviously, when you look at under 5s, about half of the deaths under age 5 are neonatal deaths. They will be very different in terms of cause of death distribution than the adolescents, where road traffic accidents, neoplasm, maternal mortality, malaria, drowning will play a growing share. So how can we estimate that? Danzhen told us about the different data sources. In terms of surveys, the sibling survival histories are one way where we can get some information. And typically, as I said earlier, they have questions about pregnancy-related death, and they can sometimes also have questions about violent death. Some DHS and possibly also MICS have specific questions about the violent mortality, which will be key in the age group that we are interested in here. Censuses might also be useful, not the census per se, but we have seen cases like in Mozambique where they conducted a post-census verbal autopsy study, where they went back to the households where household reported a death, and then conducted a verbal autopsy to have a nationally representative set of data on causes of death. And then obviously the health demographic surveillance systems are also a key data source for those countries where mortality is concentrated, and when we don't have good vital registration data on causes of death, again coming from verbal autopsy.
Thank you, Bruno and Danzhen. For our participants, I'm scanning all the questions, and if there's any question which has already been answered or on a topic, or if it's a question which is not relevant to our main topic today, I'm skipping those, just that you know, just that everyone knows. You said towards the beginning of your presentation, Bruno, that, well, let me put it this way. The summary birth histories, which were used, are still being used in census, I think, very commonly. And they were used once upon a time, very commonly in the MICS as well, before we introduced the full birth histories back in mid-2005 or thereabouts. They have been very useful for mortality estimation. And you did mention that there's not an equivalent method, indirect method, for instance, for this age group. What would be the challenges for the development of that? Because it's been a very long period since we have been using the summary birth history based indirect methods for under 5 mortality, but not for this age group. Is it because of a lack of interest, relatively speaking, on this age group, on mortality, or is it about modeling challenges or other types of challenges which have made this not possible so far?
Oh, thanks, Attila. This is a great question. There is a mix, I think. Lack of interest, definitely. I think those age groups have been neglected somehow by the, I would say, global health community and the demographers in the past, and now they are getting more attention. So that might also reflect why there has not been such a development of the indirect methods for those age groups. There is a lack of data, because if we use the summary birth histories in the census and the DHS, you only have the number of children ever born and surviving. And as Danzhen has showed, 70% of the deaths that occur before age 25 occur below age 5. So the burden of mortality is still concentrated in neonates and young children, right?
Mm-hmm.
So that means that your proportion that you get from the summary birth history data, the proportion of children dying is still very much reflecting this burden of mortality in children below age 5. So what we need is a method that would extract the information to cover what happens above age 5 or above age 15. For above age 15, we can use the summary sibling histories. But so again, censuses and surveys should at least include summary sibling data when they don't use the full sibling survival histories. There's just a short number of questions. But if we were to develop the method, indirect method for older children based on summary birth histories, I don't think there is a lot of problems with the modeling because the method is quite simple. It's based on stable population theory. We can recompute the coefficients that have been computed for young children to refer to older children. But we need to find a way to extract information on the age from the proportion of surviving children. And currently, we don't have this information. The only information you have is the age of the mother that is used as a proxy of the duration of exposure of the child to the risk of dying. But you don't know whether this child died early or late, and in most cases, he or she died early. So, but I think we can look further into this in the coming years, and I have hope that we can come up with an estimate, a new method. Another way would be to have a summary birth history with an additional question where women are asked about how many children they have, how many of those children died, how many of those children died before age 5, and how many of those children died above age 5. And then we have the information we need. But for this, it should be piloted in surveys, but it would be a way to then recover information on the age that currently we don't have.
Thanks, Bruno. It sounds like there's a lot of methodological work still needs to be done, but I think this is great work, and I congratulate IGMI, Danzhen, yourself, and Bruno, all the technical experts who work on the IGMI for making all this data available, which is quite challenging. So thank you very much. I don't see any other burning questions in the Q&A. So once again, many thanks for participating in this webinar. Thank you to our presenters. Great presentation. Thank you to all the participants. And I leave the floor to Danzhen to take us through the last 2 minutes. Danzhen. Sorry,
Thank you.
Archana. Danzhen and Archana then. Danzhen, any last words from you?
There's one recommendation for service to include mothers' demographic, social, economic status, etc. Yeah, which indeed is quite important, and I think for country government agencies to consider that as well. But yes, from our side, we will also advocate for the relevant data collection.
Thanks, Danzhen. And last words from Archana?
Yes, thank you so much, Bruno and Danzhen, for the excellent presentation and for all the participants for their great questions and comments. And also wanted to acknowledge Lucia, who has been answering some of the questions written. So thank you so much, Lucia, for also joining. I'd like to remind you that the next webinar will take place in 2 weeks on April 17th. And the topic is estimating level of effort and cost for implementing household surveys, the case of MICS. So we hope you'll be able to join us for that. A final reminder that the recordings of this particular webinar and all past webinars are available on the MICS YouTube channel, and for UNICEF staff, they're also available on the SharePoint site. So with that, thank you again, and we will see you in a few weeks. Bye-bye, everyone.
Thanks, everyone. Bye-bye.
Bye, thanks.
Thank you. Bye.